session. So I will probably start with an introduction first. So I'm Michelle Gyani, and I work as a manager at Gallup Pakistan's public health program. And I look at different programs or different projects within the ambit of public health. And one of these projects I look at is the Let's Talk Public Health series, where we do bring experts on board to discuss pertinent issues in public health in Pakistan. And today we are joined by Dr. Roomi Aziz and to discuss a very interesting topic. I'm fairly obviously said it is quite new to me as well. It's about the health needs of the migrant population, and just looking at it from different aspects as to what different vulnerabilities that population or segment of the population might have, and what can further deepen those vulnerabilities, like say through structural or institutional issues or causes. And as for Dr. Roomi, she is a public health policy professional from Pakistan, and she is currently a doctoral researcher and assistant lecturer at the University of Essex in the UK. And she has over a decade of experience working in health systems and the social sector social development sector as well. So I would also like that if anybody else has joined, if they could also introduce themselves briefly, and then we can hand it over to Dr. Roomi to begin the discussion.
My name is Fatma Suleiman. I joined Gallup a quarter back, and I'm working on different social research with them. That's all.
Thank you.
Assalamu alaikum, everyone. Thank you very much, Dr. Roomi, for giving us the session. My name is Momina Junaid. I work in Gallup Pakistan as a research executive, and I have a background in economics. I'm also very interested in social issues, so I'm very and I'm very eager to learn more from you in this session regarding health.
Thank you, Mona. Dr. Roomi, I think we'll hand the floor over to you now. And
thank you. Thanks, Michelle. It's Michelle, right? Michelle.
It's Michelle.
Hello.
Hello. Yes. Sorry. Can you hear me? Yes. Can you hear me?
Yes.
Okay, great.
Okay, hi. So, about the topic today, when I was asked about, if there are pertinent public health issues, I just thought based on our experiences and different kind of works that we have been trying to do in the past couple of years, I think migration and health is definitely an area which needs more discussion around, more people getting interested in and taking up new kind of works, producing research and talking about it. And I'll tell you why in a bit. But generally, within the development sector and within health sector globally, migration and health has been coming up more in discussions and deliberations. Usually, health has been the agenda broadly of WHO and migration of IOM and UNHCR in case of refugees, for example. But because of the way this intersects, the way there has been lobbying and advocacy for health and all policies, there has also been recent lobbying for migrants and all policies, especially with the whole Agenda 23 logo of not leaving no one behind and making sure that everyone is a part of everything and everyone has access to every kind of a right of life facility, for example, health or education or social welfare, etc. Livelihood opportunities, living opportunities, registration, and everything that a person should have rights to. So when the Global Compact for Migration and Health came back in 2018, it kind of centered this agenda that, there are these needs and there are these migrant populations which are not otherwise covered by governments across the world. And for a very long time, the entire agenda has been led by Global North because of migration from Global South. So migrants have been seen mostly as a threat to the health system, as bringers of infection and bringers of pandemics and bringers of all kinds of things that their own countries are not prepared for, as a drain on their own resources, as somebody who is there to usurp their jobs, their education, and you get the flow. So, which is funny because if you look at the total global population of migrants, which about 100 million now, most of these are being housed by countries in global south. I mean, until the Syrian crisis, Pakistan was the country to host the largest population of refugees and migrants across the world. And even now, it's on the third number with second number with Turkey taking lead, and it varies with each year's reports. But the idea that despite the countries in the south hosting most of migrant populations, there isn't a lot coming up from here in terms of how their health needs need to be streamlined or incorporated within the government system, or how their other needs, for example, their education, their integration into the economic system of the country, how should that be designed? And you don't see a lot of xenophobia happening at this level. But like I said, the broader narrative in terms of policy directions, in terms of available evidence, available research, it's all coming from the global north, and it's all coming from the perspective of, oh, they're here, and they're here with their unique health problems. I mean, the entire idea of having a school of tropical medicine was the belief that there are these people from tropical regions and tropical zones with their own diseases which have nothing to do with us being in the north, and how do we tackle this, and little about how we are facing these problems here in Pakistan or in countries in the southern region, and how are we integrating their health needs, which has kind of worked sometimes, at least in Pakistan's case, because the first time I attended a workshop on migration and health was sometime it was about 4 or 5 years back now. And when I was asked about, and there were participants in this workshop, this was the British Council and Queen Margaret University supported workshop, and it was in Nepal, and it was being hosted by the Migration Health South Asia Network, which I now am a part of. But at that point, there were people from India with very thick and rich accounts of, how migrant populations are dealt with, and the whole structure of interstate migrants there. And so they don't it's a very different context, with because of a very large country and very different states and different languages and very different distinctly different appearances. They can easily be identified if there are people from X state and they're working in Y state, and then the whole interstate migrants and all the resulting constructs and resulting challenges with that. Nothing like, but not, and it's a different kind of challenge. And when I was asked about, what is the situation in Pakistan, and by that time I had worked for good 5 6 years in public health, and I just said that, we don't hear of migrants or migrant related challenges at all. Yes, we have a sizable chunk, which is the Afghan refugees, which has been 4 million, 5 million, now 1 million, based on how many are being repatriated to Afghanistan, how many are staying here, and then their children and their children of their children, etc. But the idea, but the interesting fact is that because we are kind of blind to migrant needs. We have not been repressive, or we have not snubbed their needs, which means, in other words, that when a Pakistani goes to a public sector health facility, she or he is not asked for their national identity card, for OPD at least. And this is the case with Afghan refugees as well. And because they all, the entire Khyber Pakhtunkhwa, Balochistan, Afghan belt, they speak the same dialect of Pashtun, and I mean, various versions of dialects, and their appearances are similar. They are not turned away when they come to a health facility per se. Now, there are other challenges with what health facilities are within their access, because they are living in camps, and there has been some seeping into the city, other cities and other provinces, but most of their population is limited to camps and campsites that are being managed by UNHCR and NCCAR, the Commission on Afghan Refugees, and so on. And they are being monitored by the Ministry of Interior and Foreign Affairs. But the fact is that in terms of health, at least, if they go to a health facility, there are no rules in place, there are no policies or systems in place that would stop them from getting access to health. Now, that might change with the new programs coming up around Sehat Sahulat and the National Health Insurance Program, because there were discussions happening around we should be only offering insurance to Punjabis in Punjab. Not Punjabis ethnicity, but people with a domicile of Punjab in Punjab, or people with a domicile of Gilgit Baltistan in Gilgit Baltistan. With the idea being that encouraging people, like the system, the GP system is in UK, to visit their own specific health facility in their region, so that the load can be managed and monitored. But the problem then would be that people who are this chunk of population, at least the Afghan refugees, for example, they would not have access to the health system, right? Because they would not have a domicile. They have different kind of identity cards. And the fact that in health it has not been a challenge so far that has come to our notice in terms of access, again, not in terms of the kind of problems they face or the kind of health problems they are predisposed to because of their poverty, or the kind of life they are living in, the kind of facilities they have access to. But the fact that they do not have a national identity card has definitely affected their access to higher education, to better employment, or to breaking that cycle of poverty. So there are generations and generations of people living in the same situation. And this is not just for the Afghan refugees. So, and globally, when I'm talking about migrants, we have all kinds of migrations happening. There are legal and illegal, there are regular and irregular. There are people who are, for example, Afghan population that's here, and they have been here for almost 40, 45 years now. There has been two set of children born, two generations born since then, who are also not considered Pakistani, for example. So the fact that they are born here does not change anything. But in some countries, if you're born in that country, you become a citizen of that country, right? Then there is the entire there are migrants by will or by force. For example, people who are fleeing Syria, nobody's pushing them out of Syria. Nobody was pushing them out of Syria. But then would you call it by will, or would you call it by force? Because there is no other life possible there, right? Then there are circular migrants. For example, in the Nepal belt, there are people who live in Nepal, and during the season they come down, and there is a porous border, so they enter India, they work there, they make money, and then when the season goes back for the harvest and all, they go back to the. So there is this seasonal migration, and this is really really common in India, with a lot of interstate migrants happening, because there are people from. There's labor from a state that goes to another during the harvest season, supports with the harvest, and goes back. And then there is migration happening because of environmental changes and because of conflicts, of course. There has been extensive migration of people with Hazara ethnicity from Pakistan for the fear of persecution. Other minorities, for example, the Qadianis, and um, so it's there is a lot of that happening. And it's not that, in terms of when we talk about health sector, it's not that we do not, in Pakistan, we do not recognize migrants. There is a migrant health policy, but it's for legit, legal labor from Pakistan, which is going to other countries. And it's about protection of their health. It is about their health screening. It's about their health rights. It's about how they will be dealt with before they are leaving for any other country, how they will be provided with facilities, and when they come back, what facilities can they be looking for? And the Ministry of the National Health Services, obviously, I mean, looks after this, but this is mostly taken care of by the Bureau of Employment, Overseas Employment, and the Human Rights Development and Overseas Employment. So it's interesting how there are these bits divided. And there is, I mean, if people would ask us on a broader forum, yes, we have a migrant health policy, but it's not addressing all kinds of migrants. It's only addressing outward migration, outward international migration. Whereas in Pakistan, we have about, I mean, there are varying figures, but between um, at least 1 million Afghan refugees. We have 1 million Bengali speakers, Bengali migrants who came at the time of the 71, the war of 71, and who kept coming in until later as well. We have about 100,000 migrants from Burma who also came at that time, and then there are smaller chunks from some people from Iran, some Iraq, and a lot of this diaspora is living mostly in Karachi, very less in other places. And there have been recent, I mean, there has been a recent documentary by Khala Jamil. It's about, I'm forgetting the name, but it is about the access Bengali speaking Pakistanis have to Pakistan, the government related health, education, social welfare, better employment opportunities, better economic development opportunities, the lack of access thereof. And there is a similar movie, it's called The Promised Land. It was produced by this Bengali director about, I don't know, 15, 20 years back. Um, and I think it's called Sonar Bangla, The Promised Land. It's about these almost 500,000 people who were unable to migrate from then East Pakistan to West Pakistan. They never assumed the identity of Bangladesh. They called themselves Pakistanis, so they never took that identity, but they were never repatriated to Pakistan. And during the Musharraf era, about 100,000, about 100, 200,000 of them were repatriated, but the rest didn't. And so they have confused identities. They are Pakistanis not living in Pakistan. They call themselves that, right? But then there are their children who have mixed identities because they have grown up in Bangladesh and they identify with that. So there is this whole Bengali speaking um, migrant challenge as well. We have the Pakistan Demographic and Health Survey. That survey essentially it captures data on migration, but it only captures data on internal migrants. So it asks about where your domicile is from and where you are living now, and on the basis of that difference, it estimates if you are a provincial migrant or an urban rural migrant. And so at the moment, we about 13% of our population is internal migrant. And obvious more of this is going to be in Punjab and Sindh, to a lesser extent in Balochistan and Khyber Pakhtunkhwa. There's a lot of rural urban happening.
Can I interject?
Sorry,
I say,
please.
so,
Sure.
I mean, from everything that you just explained, so if we just bring the context to Pakistan, and so there, essentially, you're saying there are two forms of migration, right? There's one where international, you've given examples of Burma, Afghan refugees, and then there's internal migration happening. So, and on the basis of international migration, where say if we take the example of like Afghan refugees, right now in the healthcare system, is there or is there not any discrimination happening right now? Just if somebody is an Afghan refugee and they go to access care at any healthcare facility, are they discriminated against or are they not?
I am coming to that. So I'm somewhere here. I'm just trying to just cover this bit, I think, and then I'll just jump into the challenges they have in health access. Okay? Right. So, no, I'm not saying that there are two kinds of migration. I'm just saying that migrants can be uh, classified or categorized on the basis of many things: international, national, legal, illegal. It can be in precarious situations or out of will.
Mhm.
It can be because of their job or because of their marriage. It
Mhm.
could be because of where their children are going and now they have to go there.
Mhm.
And then I was just talking. So, I mean, there are many reasons. And in Pakistan, the migrant policy is only about Pakistani people who are going out of Pakistan. It's not about even people who are non-Pakistani and coming to Pakistan. It's not about.
People who are leaving, but what I'm trying to understand is that the categorization, if in Pakistan, if somebody were to ask you or ask anybody, what would constitute the migrant population, and say from
So we would, yeah. So we would say that within Pakistan, the migrant population, which is international, is this much, which is national is this much within international. But the problem is that
but we are not.
uh, refugees, asylum seekers. I mean, we do have about 10, 15,000 asylum seekers from the world inside Pakistan. So we do have refugees, we do have asylum seekers, and we also have a lot of illegal migrants, and we also have legal migrants. The problem is that I am because I'm talking only about migrant, the as an overarching term. You are asking about migrant from me, but problem is that, for example, if you today start looking for literature on migrants in Pakistan, you will not find a lot because refugees are not classified locally as migrants.
So that
Asylum seekers are.
what's missing from the literature at this point is basically the reasons for the migration, basically what's driven people, whether it's internally or internationally, what's driven them to
No, the entire no no the entire net, the net is very, it's a very narrow outward looking net. It's a net that's serving the purposes of some bureaus for better accountability of people who are leaving the country through government schemes
Mhm, mhm.
and through bilateral two government, three government arrangements. So it's serving that purpose only at the moment. The problem is that this is not just a Pakistan based problem, but it's a global problem about how do people classify migrants. I mean, we are doing a policy integration exercise, and we have been receiving feedbacks from experts who have asked us that, you're saying migrant, but do you also mean immigrants? Do you also mean refugees? Do you also mean asylum seekers? And do you also mean aliens?
Mhm, mhm,
Because the Bengali speakers in Karachi, they are called aliens.
mhm,
People who have been unable to, not all of them, but people who the government deems have been unable to prove their um, living, their residence in the country from before 71, something on those lines. So when you so I because it's me who's speaking, I'm explaining it like I understand it, that this is the whole migrant chunk for whatever reason, from wherever, moving in and about, not living permanently and not of Pakistan, for example, right? But this is not how the general description works, which
yeah,
which is why, yeah, which is why if you will say it's based on international and national, then the entire by force.
that data or that categorization has not really, that is missing from literature, or Pakistan does not have any, concrete source of information or sources where you
There
can.
are, but they are in bits. No, no, there are sources. I mean, there are reports, but they are in bits. For example, for internal migrants, you will find the data in the Demographic and Health Survey. For the Afghan refugees, you will find it in the UNHCR updates.
But
For the
you're
people,
saying that it's broader than that. That's basically what you're trying to say, is that it's a
I'm
lot.
just saying that, yeah, I'm just saying that the idea is that if there is a health system, I mean, we are talking just for the health system, but if there is a health system, an education system, a social welfare system like the Benazir Income Support Program or the SAS social welfare program, it we saw this during the pandemic. The entire scheme of SAS social welfare was based on the BIS registries, right? And BIS registries were based on Qawmi Shanakhti Card,
That's,
our
yeah.
national identity card, which excludes a, a lot of groups from this population.
Beneficiaries have been updated up since the first time the program started. So I
But
did.
it is still based on. It's still based on.
does exclude a very large segment of the population inherently, and then further, if you also categorize even further, then it would exclude, of course, the migrant population as well.
Yeah. So wait, so and then I mean they and it's very we our response as a government to these needs, it's not. So I'll just say there hasn't been deliberate um oblivion. It's not deliberate, especially because of the kind of challenges that we have. So the common discussion is, we have so many challenges. Why are you just focusing on adolescent health? Or yeah, so it keeps coming down to that. So it's not deliberate, but there are some very simple things that could make them more visible, and that could make the system more accessible and more approachable for them. Because and we our response is so knee jerk. So because when the flood will happen, when an earthquake will happen, when these IDPs will come into place, we will set up these camps and makeshift hospitals and makeshift clinics to respond to their acute injuries. But nothing about the problems that this, and we saw this in the floods last year, right? So people were posting pictures all over the social media of, look how bad their people conditions these people are living in. They've lost their houses and they're only eating potatoes and roti donated by different agencies. And I was like, even before the flood, they were not eating sheer khurma and shabdeg in any case. There were these challenges even there before that, but our responses are very knee jerk. So when, like I said, floods and earthquakes will happen, we will be responding to IDPs, because provincial migration is not much of a in Punjab you don't see that a lot of problem because of the size of population. You will see more acceptance for people from other provinces. In places like Karachi, it's very metropolitan. You will see more Sikhs, more Hindus there working, and it's very common, but you won't see them anywhere else in Punjab. And then you will also not notice, because for I am from Punjab, so we are the majority in Punjab. We will not notice if there is somebody from Khyber Pakhtunkhwa who's working there, and the kind of challenges that she or he would be facing in terms of getting integrated, in terms of not being able to speak the same language. We would be more vocal about the challenges we experience when we are working in Balochistan, or when we are working in Khyber Pakhtunkhwa. So the provincial migrants, that's it's very and the fact that, again, it because we have the national identity card, if there are things that are expected to go worse, for example, if we need to get admitted to a hospital, if we need to provide that kind of documentation, we are able to do that, right? But it's not the same case everywhere. And there are challenges, but the problem is that you don't see that kind of evidence, and because of the way it has been framed. So if I'll be specifically looking, I mean, if there is like a scoping which clearly looks for all kind of possible identities that are coming up. For example, if I look for what kind of health access challenges to Bengali speakers in XY colony in Karachi face, and then I'll come up with evidence. It's also how we are framing it, right? So getting it together at the national level becomes a bit tricky. And then the problem is IOM's agenda is not is it's migrant workers health also. It's less of refugee. UNHCR is focusing only on refugee. So the whole thing does not come into any one umbrella. So when you asked about discrimination, there is no discrimination, fortunately, because but it's interesting, you will have you been to Lahore?
I'm from Lahore.
Okay, so you know about Uriga, the big cloth market.
Yes.
Have you heard this ever, that there are all these Pakhtuns who have come and taken over the cloth market?
Yes.
See, so it's very subtle, but it's there. And we don't call them migrants, but we identify them as not being us. This is
This is also, so this is a form of like in this specific scenario, this would be internal migration, right? Where from one province, or
but you don't, yeah, we are only concerned with them being Pakhtun, not even, and we don't even know if they're Afghan refugees or they're just people from Khyber Pakhtunkhwa. Yeah. So this is within people's behaviors generally. So, and you don't know, this is like a cloth market where they are there to earn their livelihood. We are not doing any service to them. We are
they're not, so from again, from a health perspective, they're not being discriminated against for
you think that's what I'm saying, in a neutral ground, like a marketplace, a fair marketplace where they have goods and we have the means to buy the goods, we still hold this perception. So it's hard to say that kind of perception does not exist within health system. Having said that, our outpatient departments are designed as such that we do not require, unlike a lot of countries, for example, in India, you have to give your Aadhaar card and ration card before you access health systems, even OPDs. In Pakistan, it is not the case so far. So if I'm sick, I can go to any district headquarter hospital, any tertiary care hospital across the country, even if I'm not from Pakistan.
Yes.
And if I look the same skin, so if I look like some European or American, it's a different story altogether. But because if I look like a Bengali, if I look like a Pathan, I would not have a problem, at least at the level of OPD. But this, we're talking about people who have managed to go to the facility. The problem is that where there are these camp settlements, there aren't many health facilities there. We have our own tiered system of basic health unit per 100,000 population, rural health center, or tertiary, or DHQs or THQs. But for the entire settlement areas, this kind of arrangement does not exist there. There are different kind of camp arrangements, and we do and the fact that we cannot separate health from the social determinants of health. The access to food, the access to other opportunities in life, the general poverty that they are living in, the general difficulties that they are living in because they are not being considered from Pakistan. And then within those populations, the kind of sanitation related challenges, wash related challenges, access to clean water for drinking, access to toilet, for example. So a lot of this is determining their health, right? So, okay, if there is no discrimination at OPD level in public sector health facilities. Private, I'm not saying, because private ask also for money. They may, it varies because there is no single rule applicable to all of them. They will ask for money. They may or may not ask for an ID. The problem also comes when there are hospital admissions happening, because for hospital admissions, they are required to submit paperwork. Now, based on some interviews that I did with Afghan refugee for an Afghan refugee related work, it seemed that at least even at the level of admission, the ID card that they're given, the alien ID, it's called the national it's a national identification similar to like an ICOP, but they are given different looking card. And you may have seen that we saw this during the COVID vaccination registry. Remember, when we were registering for an online COVID vaccine with the government portal, we were asked to give our national identity card number or an Afghan refugee card number, whatever a number is. So that based on that number and that paperwork, they can get hospital admissions. So after looking at other countries and different health systems, I would say our health systems it's far superior because we are considering four criteria, right? It's available, accessible, affordable, and quality. I'm not commenting on quality, but it's available, it's accessible, and public sector facilities are affordable. I mean, they are free for services wherever it's concerned, and even with hospital admissions and all. And it's not the same in other countries, of course. And quality, again, because we do not turn anyone who is sitting in an OPD will get an appointment, even if it's at 5 in the evening. It's not like other countries where we are waiting for an appointment and it might not happen in months, 2 months, 3 months, maybe. So it's different like that. So our health system has generally been open. It has not discriminated on design, but our system in general it's a discriminating system because of how our facilities are designed or how our features are designed. So when we talk about not having policies and programs for migration, migrants and health, uh, what these policies or systems should be doing is encouraging people, making sure that there are referral outposts, for example, in the settlement areas, so that people can come in. Now, the problem is a lot of times, if for example, I have been discriminated because of my sex in a new city, or in yeah, I'll assume that this is the kind of behavior that will be towards me in most of the other public sector places, right?
I
So,
need to add something.
yeah,
You
sure.
told me that there are a lot of immigrants, especially from Afghan border, that their generations have been living here for so long and they still don't have any identity. Maybe children get married and they give birth, and then their children don't have any identity. So, isn't it there should be a process first to give a identification for the people like who are like they want to live here for the rest of their life and they have kids here, and obviously when they have kids and families here they will have a lot of issues related to health and they will be needing services. So identifying them and then giving them certain identity, because without ID card nothing is possible in terms of health and in education.
So you're done, Fatma?
Yeah.
Okay,
So
so
isn't it
no,
this is the core
it's
reason?
no, they're not without identity. They have an they have an Afghan refugee status. They have an Afghan refugee card. It's not like they're without identity. I'm not saying that. I'm just saying that
But their kids
the
also have a what their
yes, they
kids will
also
have.
have, yeah, they have what their parents have.
They don't have
Okay.
nationalities, so they don't have a
Yeah,
Pakistani,
they don't. They
but they
don't have a Pakistani nationality, so they do not have access to because a lot of times the first thing that we think of when we are introducing any scheme for verification is the national identity card.
Yes.
If it's issuance of SIM. The thing is that because they have been with us for such a long time, about like half a century almost, our SIM issuance and our hospital admissions and our COVID vaccines and things, they are considering them. They are making room for their registration. But generally, their access is problematic. Like I said, they're living in settlements. The fact that they will never get out of that predicament, that entire cycle of poor health, is because of everything else that they are being exposed to, right? So when we talk about responsive health policies for migrant needs, we want to take those elements also into consideration, that understanding that the kind of situations that they are living in and the kind of settings that they are forced to live in and not out of choice, these are the health problems that will be there, and this is why health system needs to be more responsive, which means that maybe and ask them, include them in the process of what is their need. It's I cannot think, you cannot, we cannot think of the kind of problems that they are facing. Accessibility is a problem. The idea that maybe I'll go to a bigger city like Peshawar and will not be able to afford it is also a problem. So not having the knowledge of affordability is a problem. Not having and not knowing the language is a problem. Not being able to speak in that language is a problem. Fortunately, they are in the entire Pakhtun speaking belt, so they do not come run into those problems a lot. More or less people can speak Pashto. But the problem again is it is you or me who are discussing this and very little coming from there. We are doing a couple of exercises in Pakistan, one of which is a review and a review on the lines of Equifrim and MyPEX on how responsive health policies and health related strategic frameworks are to any kind of migrant need. And by that we mean, are they even mentioned or considered as a population? Because it's like, I remember we were working on HIV/AIDS, and we had made this matrix of awareness and discrimination. And people who are extremely aware may not be discriminating. And people who are completely clueless are also not discriminating. It's the middle group which has some knowledge and start discriminating. It's similar to migrants. That's a personal opinion. I just feel because most of the people within the health system are just boggled down with whatever is happening there and the immediate problems at hand, that they are not really aware that this is a subgroup of population that needs to be taken care of or catered to. As a result of which, like I said, our policies, our programs, our health sector facilities, are the way we have structured it is not it's not ignoring them, or it's not excluding them, but it's also not including them. including them. I mean, one of the bigger things that we talk about in terms of diversity in health workforce is having people who look more like people they are serving. And which is why the community health, our lady health worker program has been a success. Women serving women, women talking about women's needs. But how many of uh, how many of refugees, or how many of Bengali speakers, or how many of Burmese migrants will you see within health workforce? So these are all. I mean, it's a whole paradigm of what component, whatever, whichever component within the health system can be made responsive to and can be made transformative for migrant needs. It's not just about people discriminating and stopping that, okay, you're a migrant, you cannot come to this health facility. It's not just that.
So yes, like you said, of course, this is more along the lines of a lot of the social determinants of what would actually be indicative of a migrant's health status in present and in future, and through intergenerations as well. And if we talk about, say, a migrant health policy, right now you have specified that the one that we currently have in Pakistan is just tailored towards people who are exiting the country and their needs. So if in an ideal, if a scenario, say you were to think of a migrant policy which caters to all different forms of migration in Pakistan, what do you think, because this is a policy, institutional and a structural problem, and what do you think would that look like in practice? Because a lot of the times we do have policies in place but we do not really see them being implemented. So in practice, what does that look like? And just for a reference point, like, say for example, one system that Pakistan has set up, which I think is fairly successful, has been the IDSR, right, which is the integrated disease surveillance and response system, right? And that is for, I can't say like with full confidence how well it is doing, but it is a system that has been set up currently to monitor like 33 infectious diseases across several districts over the country. So a system like that, again, leverage technology and is making use of that technology to monitor disease burden across the country. And that, in my opinion, is like a very concrete system that I could use, or I could give an example of. So what is something like that, or even in in policy terms, what do you think would be a system that could be set up to cater to this issue?
Um, it's funny, Michelle, you speak about IDSR, which I don't even want to speak about, but um, there has been different kinds of surveillance systems, much better state surveillance systems in Punjab, 33, 34 diseases being monitored. This is from 2016-17, actually. So it's not, but there is no one IDSR system. Provinces keep introducing different kinds of surveillance programs and notifiable diseases, and then they keep calling it whatever names, but there isn't any singular national database or that national monitoring. A big success happened during the national command control thing for COVID, right? But it's not something, I mean, if you are giving that as an example of something that's successful or practical or usable, I'm not sure. um I would not take that as an example.
If you were to limit to a province, like for example, right now there's a lot of data that's missing on migration, right? Like for example, there's fragmented data on, like you said,
Yeah.
it's available through a demographic health survey or through other one source of information.
Mhm.
What I mean to say is that IDSR obviously is not an ideal system. What I mean to say is that if I want, say, just on one, if infectious disease, if I want consistent data from the province of Punjab, I may be able to access it over a several number of years, right? Where
Yeah.
since the system has been set up, right? So
At least the data from the district health, the DHIS to the district health information system.
that's
Yeah. There are gaps, but that system has been there in place. No, so the problem is we also do not have a lot of evidence We don't have research around this. And because we do not have research around this, we do not know that what are the needs or where are the challenges, what is the problem, what are the actual problems that they are facing that need to be addressed within the programs and the policies. Do they need more communication material tailored to them? Do they need more
IDSR is a separate. I understand the IDSR
no,
has
no, no. I'm talking about migrants now.
for the migrant. So what I'm asking is that where should the government, because obviously this would be a government level policy or government level issue.
Yeah, yeah.
So where should the government be starting off from? What should they be doing as an ideal first step to get to a point where they can eventually establish a system?
Research.
So
For sure. The first thing, and it's not just the data that is within the information databases. It's not surveys. It's actual research, understanding, um, properly understanding what kind of problems they go through, and picking people from each cluster to see what kind of problems they go through when they do try to access a health facility. For example, do they need, like I said, do they need a communication targeted towards them in their language, for example, or in the places where they are living in? Do they need more targeted interventions or different kind of drives there? What's working over there? But we do not have that evidence, which is why it becomes even more difficult, because there is no ready evidence. It's very difficult for policymakers, because if, for example, today, if you are the minister for health, if you are the chair for the planning commission, and I come to you and I say, Michelle, madam, I want to talk to you about this, and I have made a pleading case, so you've listened to this hour of my work, and you said, okay, so it seems migrants are a big problem. I want to make sure my new policies and programs are responsive to it. You tell me what to do. But I can't say that, because there isn't that evidence. What we are doing, although at this point, is that the policy exercise that I told you about is about seeing, and that would be a powerful case to show, because it's being measured against a proper, globally vetted, validated index, which we are trying to customize to global south context. And it is talking about places where policy or programs should have been responsive to migrants and are not. So that is the first place we could start in. The second thing that we are also already doing is doing, it's similar to Delphi technique, but it's not entirely that. We're doing a Chinri exercise of research priority setting in Pakistan for migration health. We are done with round one. We have received research priority topics from about 65 people from about 127 institutions across Pakistan. And these are research priorities that they think are for migrants. So starting with that, so that the next time I speak to you, Madam Minister, I can tell you that A, this is where our policies lag, and B, I want you to work with academicians and commission research on these 12, 20 research priorities that have been identified and ranked by researchers from across the country, that this is the first step that we need to do in order to understand uh, the challenges migrants populations go through in terms of health, and kind of policies or programs that would ensure that this doesn't work. I'm personally not, I do not like giving, I generally try to avoid giving one-stop solution like this is what needs to be done, because fairly for the purpose that I just do not know. I just know that this needs to be kept in mind, and I just know that there are these 2 or 3 exercises that we are doing that will take you a step further. These, and I had similar yeah, so I mean that's what I hope that answers.
And it also, because in Pakistan, obviously the healthcare system has always, up till date is quite fragmented. There've been challenges with
It's still such a good system. It's such a good system still.
it is, in spite of all its challenges, there's obviously a lot of plus sides to it as well. So, but it just, and that's the thing. But I mean, I'm not an expert in the field, so I can't really also just say, that this would work or that would work. But a lot of the times when we do have discussions, like say from policymakers or even from health professionals and doctors, when we brought all those people on the table, like during floods, etc. So a lot of those discussions are tailored towards making policies, whereas I generally do feel like we are at that stage, given just the way our population is structured, where you've got a significant portion that's a younger aged population. is where you kind of do need to move towards having more radical solutions, right? Where it can't just be something that you write a policy down on paper and that's it. So
Yes, I
that was just
I
my
know it. I know. No, no. I know where you're
Yeah, I
coming from, but
totally
the problem is that when the approvals are happening for uh public sector, public monies funded programs and and projects, at that point in time, the if there is, for example, a minister and the secretary, they are not subject specialists. They are administratively very seasoned. They need to rely on the inputs from experts, which are not always accompanying every scheme that comes to them for approval. And then they have to rely on what does the country or the province say in terms of their policy commitments. For example, a lot of programs that we were able to push in when I was working with the uh, planning commission during the COVID secretariat days, when you were also there, a lot of programs that we were able to push in were based on very significant big country commitments that Pakistan has made very vocally around gender, and the UNGA presentation that it did in 2019 and 2020 around gender. So we use that okay, Pakistan, you have committed. So because the country has committed and because this is the state of affairs in the country, this needs to be done. So now that that framework, that policy has been approved and that strategic framework is in place, now is the time for example, private sector representatives such as yourself to hook your radical solution idea to that approved strategy, that this is what you need to do, this is where you need to pilot it in, this is the money that you need to do it. And why do it? Because you, the government of Pakistan, committed in your policy and strategy framework last year that this is what you're going to do. So it's something on those lines. So I completely understand where you're coming from.
No.
Totally. But that is where the policy and the fact that when we are looking at countries, we see them at we see it very broadly and crudely. We see at them at two or three levels. Yeah. Do they have a policy? Do they commit in their policy? Do they design a program for that policy? And then at the end, is that program effective? So there are exercises which say, okay, at least this country has a policy. Making it effective is the next step. So it's something on those lines. Yeah.
I think Fatma was saying something between.
Yeah, I just want to add this. Dr. Rumi is very right that sitting here in Lahore or in any province and deciding and making a policy for them will not work unless and until we go there and we have from their own mouth that what are the main issue and they are facing and how we can resolve them. We can also take their inputs. That will help a lot in making a policy or something set up which will actually work.
No, absolutely. I mean, the policy integration exercise that I'm doing, a big making it transformative means including them at every level, whoever they may be. If it's a women's reproductive health strategy, where are the women? If it's a lady health worker program, where are the lady health workers? And not just their token representation at the launch ceremony, but also their participation throughout the program. And I've come to know that, for example, the latest lady health worker program strategy. I mean, there were a couple of people present at the ceremony, but it was reiterated and documented that through every stage of the program design and the strategy design, lady health workers were effectively made a part of it and they have contributed to it. So that kind of representation and that kind of integration of their needs and their challenges, and budgeting comes towards the very end, but much before that, I understanding the problems that it's like, I'm not sure, have you ever noticed working donkeys and working horses? I did this work for an organization which is global, and it works only for working, not for ornamental horses or race horses. It only works for working donkeys, working mules, and working horses. And once you have seen it, you cannot unsee it. And the idea is, which is what I also wrote in my LinkedIn post. Once you have seen the kind of challenges that they're going through, the access they have, their animals have to health, the problems in our veterinary training programs, because they're basically trained on the cattle, which is included in farming and not for working equines, and the extensive loss, decline in their population. Once you start seeing it, you cannot unsee. The idea about generating all this discussion is that when you are, for example, in a room where something of the sort is happening, you just raise your hand and say that I understand that this is there, but keeping to the country's commitment to SDGs and leaving no one behind, we are maybe leaving a sizable chunk which is so vulnerable because they do not essentially belong to this country. But our constitution says we are responsible for everyone living here, and not just the citizens. So using these framings to, lobby and bully your way into talking about these challenges, and then saying that I would have come up with concrete challenges, but the topic is so ignored. This agenda is so ignored that there's not even enough evidence around this. I mean, if you will see research around Afghan refugees, it will be like lice infestation, reproductive health challenges, and it's very local and very it's a very micro, maybe meso level. It's not at a macro level that why is all of this happening, which is why they are in this state. And also the fact that we are an entire park of one border, it's a very porous border. It's a very, very porous border. So we have 19 points of entries, but we have like zillion points across that. And there are people who are married across borders, and they are moving freely across borders. So it's tricky. That management is in any case tricky.
So I do want to open it up if anybody else has any questions. I feel like I've taken up more of the time in questioning. Fatma, Mumna, if you have any questions, please go ahead. And
One good example that I want to add here is, for example, polio is a very good example, especially its unacceptance in our, obviously in Khyber Pakhtunkhwa and these parts, where when we realize that the core issue is that they consider polio as a very different thing, and then educated them and letting them know that how it will help them in increasing the acceptability in them. So I think reaching out to them and also getting them know that what we have for them and how these issues can be resolved, I think will be a good initiative in the start.
Yeah, I mean, it's one of the many things that is happening and needs to happen. It's and also, I mean, generally the framing of them is where the problem begins. So, and when we talk about, things they are facing or why they don't want to do it, or we need to explain it to them because we are their citizen saviors and they are not. So, and there's a lot of indigenous intelligence happening at different levels. We have not incorporated that ever. So that needs to be taken into account. But yeah, so it is something, and it was something that I just thought we should be talking about. Yeah, without heavy presentations.
that's thank you so much for that. Very quickly, I would just like to ask as a last question, three things that you, or three steps that you think the government should take to address this challenge. And I would say maybe a stepwise approach. So 1, 2, 3.
I'm not sure if there are three things for the government. I know as professionals, we also fail the government because we keep giving them these tidbits and not prepare enough to respond to their queries. So I think for the first 2, 3 steps would probably be just pertaining to me or to the work we are doing at, like I said, the Migration Health South Asia Network with Southstat, be to impact that we complete these exercises of the policy integration, policy responsiveness towards migrants' health needs, that the exercise on research priority setting, which is into its round 2 now, and also the country profiling, bibliometry. So these pieces to be put together, because once that is there, it's not that the government does not listen. They are not responsive, or they do not give time of the day. It's not like that. It's just that we pick up agendas that we are not very well prepared for, or we have not done our homework for. So I do hope that the next time I speak about this, I have some concrete content with me that can be shared with the relevant parties in the government, the relevant state actors, because then they would also know what needs to be done. So if I'm not
Last
doing that, I'm
question.
failing my job as a professional. So that would be the
Last
two, three things. Sorry.
last question from my end. Do we have any example of a country that we follow that like they have done this thing? Yeah, they have responded the immigration needs in a way that we can follow, that we can show them as example to follow or as a benchmark setting that Pakistan can follow of any country.
This is a cool question, Fatma. I'm going to keep this in mind. No, I've not come across, or there are frameworks and there are smaller components within each country about how responsive they are. For example, Turkey has certain elements which are way more responsive than Pakistan, but certain elements which are not. And similarly for other countries, but I'll keep an eye out for something that I can use as a, and there are policies, some that have been very well documented, but we would want to pick an example from the south, um of how we are incorporating migrant needs, because in the north it's more around how do we protect us from them, and that's not the narrative that we want to go in with. I'll keep an eye out for this was a fun question, and it's a tricky one. I'll keep something, and I'll definitely share with Michelle, to be shared with you if there is something like that. And that could be the fourth ask from, yeah, us before we go to the government with anything.
Okay.
Thank
Okay.
you so much.
Think we're 10 minutes over time, but thank you so much for joining us today and for discussing a very important topic. I certainly learned more about the migration landscape within our country, and it was very engaging also. So, which is why I was asking questions in between, because I'm not particularly familiar with the landscape before this. But thank you so much for your time, and
Well,
very,
it's
very excited that you were able to join us today. And again, I do.
I'm happy too, because I enjoyed talking to you also about this.
All right, well, and we will follow up with you, and we will stay in touch, of course. And we would love to also keep in touch with your research. So that would be awesome.
I will, yeah. Yeah, the moment, I mean, I'll actually just share links to the round two in case you find anyone else. It's just that there's so few people. It's hard in any case. So it's good. And of course, when it's there, I'll definitely reach out to you with its dissemination and anything else for that matter.
Thank you so much.
Thanks, Michelle. Thank you, Fatma, for staying on for so long.
Thank you.
Thank you
Take
so
care.
much and all the very best for your research. I hope something good come out.
My research is on health workforce, though it's not on migrants. But this is also happening alongside. So yeah, just saying that.
Thank
Okay.
you.
Thank you.
Thank you so much.
Thank you. Take care. Bye.